Which of the following spinal fracture types is the most stable fracture? A. Teardrop fracture. B. Burst fracture. C. Unilateral facet dislocation. D. Hangman's fracture. E. Clay-Chauvel's fracture. And the answer is E. Clay-Chauvel's fracture. Regarding teardrop fracture of cervical spine, it is referred to any fracture with a triangular fragment in the involved body. It can be divided into two types based on mechanism of injury, extension or flexion type of injury. The most common is a flexion type injury. This illustration shows a teardrop fracture with a triangular fragment of the involved body. For hyperextension type injury of teardrop fracture, it is commonly a cervical teardrop fracture of C2 vertebral body. Anterior longitudinal ligament originates from the base of C2 D-axis. In cases of extension injury, the avulsion fracture occurs at the bottom of the anterior-inferior side of the vertebral body. The stability of the posterior side is maintained. For flexion type of teardrop fracture, the most characteristic features are posterior displacement of the upper column of the divided cervical spine. Other radiographic characteristics include backward displacement of the posterior fragment of the involved body, widening of the interlamina and interspinal spaces, widening of the facet joint with backward displacement of the inferior facet, kyphotic deformity of the cervical spine at the level of the injury, frequently associated with sagittal body and laminar fracture, predominantly at the level of C5. This CT scan shows a flexion type of teardrop fracture with backward displacement of the posterior fragment of the involved body. Next, regarding the burst fracture. The most common site of injury to the spine is the thoracolumbar junction, which is the mechanical transition junction between the rigid thoracic and the more flexible lumbar spine. High-energy traumatic vertebral fracture caused by flexion of the spine that leads to a compression force through the anterior and middle column of the vertebrae. There are different classification systems for burst fracture. They're talking about thoracolumbar. Dennis 1983 described a three-column classification of spinal fracture. He proposed that injury to the middle column, that is the posterior portion of the vertebral body, posterior longitudinal ligament PLL, and posterior disc was sufficient to create instability. He also classified unstable fracture into three types: mechanical, first degree, neurological, second degree, or combined mechanical and neurological, third degree. McAfee et al. 1994 described another classification. He classified the injuries based on how the middle column failed, with burst fracture showing middle column failure in compression. He also distinguished between the burst fracture with or without PLC, posterior longitudinal complex disruption. Continue from McAfee et al. A burst fracture of the PLC disruption is considered to be unstable. Posterior ligaments have probably failed if there is more than 30 degrees of kyphosis and or 50 degrees of vertebral body height loss on a plain X-ray. To confirm PLC disruption, suggest for MRI. This picture shows a CT scan that reveals a burst fracture that involves the middle column with a bony retroportion to the spinal canal. Next, regarding a unilateral facet dislocation, the mechanism of injury is due to flexion and rotation. It is always associated with monoradiculopathy that improve with traction. Radiographic findings: 1. Subluxation of the affected level with 25% translation. There is anteroposition of 25% of the epidiameter of the vertebral body. 2. Malalignment of the spinous process is seen on AP view, which can only be produced by a rotatory injury. The involved spinous process points to the involved site. This X-ray illustrated the unilateral facet dislocation of C4, C5 level. From AP view, there is a malalignment of the spinous process. From the lateral view, there is a 25% translation or anteroposition of 25% of the epidiameter of the vertebral body. Regarding hangman's fracture, it is a traumatic spondylolisthesis of the axis. It is described as bilateral fracture traversing the pars interarticularis of C2 with an associated traumatic subluxation of C2 on C3. The most commonly used classification of this fracture is Levine and Edwards classification. It is almost always stable without needing surgical intervention. This X-ray of cervical spine shows a traumatic subluxation of C2 over C3. Lastly, regarding Clay-Chauvel's fracture, it is an avulsion type spinous process fracture in the lower cervical or upper thoracic spine. It is commonly at the spinous process of C7 and T1 vertebrae that are affected. Diagnosis is made with lateral radiograph of the spine. The treatment is usually rest and pain control as the injuries are mechanically stable. This X-ray shows a undisplaced of C6 spinous process fracture and displaced fracture of C7 spinous process. So this answer our question. The most stable among the fracture is Clay-Chauvel's fracture. So another summary. In summary, unstable fracture of the cervical spine involve 1. Flexion type injury. Example in bilateral facet dislocation, flexion teardrop fracture, wedge fracture with posterior ligamentous rupture. Number 2, the extension type involving an odontoid fracture type 2. Another example of extension type is hangman's fracture, extension teardrop fracture. 3. Vertical compression. Example is burst fracture that involved in the cervical spine is example Jefferson fracture. Okay, thank you. A 11-year-old boy sustained a fall while jumping on a trampoline. He has moderate back pain, a L5 radiculopathy, and weakness of the right extensor hallucis longus (EHL). Radiograph and a computerized tomography CT scan of the lumbar spine demonstrate a slip vertebral apophysis. The recommended treatment is A. Laminectomy and excision of annulus and vertebral body margin, B. Bed rest, C. Thoracolumbar orthosis, E. Physical therapy, E. Spinal traction. And the answer is A. Laminectomy and excision of annulus and vertebral body margin. Okay? The reason for this answer. And it is an analogous of Salter-Harris type 2 fracture. A portion of the apophysis and annulus slip posteriorly and may impinge on the existing nerve root. These usually do not resolve spontaneously or improve with conservative therapy, and excision is usually indicated. Slip vertebral apophysis or apophyseal ring avulsion, it is very rare. It is an uncommon cause of radicular low back pain in pediatric age group, adolescent, and athlete. This lesion is one of the differential diagnoses of this herniation. It is because the fusion between the ring apophysis and the vertebral body do not occur fully until the skeletal growth, that is at the age of 18 to 25 years old. Fracture of the vertebral ring apophysis is an uncommon but important cause of back pain in adolescents. It usually follows a strenuous physical activity or trauma. The ring apophysis of vertebral bodies appear at the age of 5 years and fuse with the rest of the body at 18 to 20 years, in some cases up to 25 years old. The annulus fibrosus is adhered to the superior and inferior vertebral plateau via the Sharp's fibers and also to some fibers of the posterior longitudinal ligament. For these reasons, the fractures are commonly seen along the posterior aspect of the end plate in the middle, midline. Rarely, it may be seen on the posterolateral aspect of the superior end plate. This figure depicts A. View of the ossified rings and the start of fusion. B. It shows an anatomical view of the intervertebral disc and the attachment of the Sharp's fibers. You can see there's a posterior longitudinal ligament there. Herniation of the disc occur through the fractured fragments, and this may prevent healing and reunion of the fragment. Study done by Potas et al. 2002 and Bay et al. 2013, the common affected region are the end plates of L4, L5, and S1 vertebral bodies. High clinical suspicion and investigation are important for planning the treatment and proper surgical approach. CT scan is the modality of choice to diagnose apophyseal fracture. It has the best performance of the demonstration of the size, the shape, the location of the fracture. Excellent demonstration of the relationship between the fracture fragments and the herniated disc is possible with CT scan. This computed tomography CT images shows an axial slices through the apophyseal ring fracture. You can see the arrow. Sagittal slash shows the double injury of the apophyseal ring. It is arrow marked. CT scan further helps to differentiate the calcified or non-calcified fracture from the lumbar disc herniation. The MRI identifies only 22% of the fracture. However, MRI helps to show the herniations or extrusion of the disc and its mass effect on the contained nerve root. There are many classifications that can be used. Among the commonly used are Epstein classification. It's a modified Takata classification based on the morphology of the fracture is used. These fractures were classified using a CT scan by Takata et al. And it divides into 3 types. Type 1. The posterior margin of the vertebra shows small separation. No abnormality is seen in the underlying vertebral body because only minimal bone loss occurs in the fractured fragment. An awkward fragment is seen to lie within the spinal canal. This type occurs frequently in individuals younger than 13 years old. A type 2 is an avulsion fracture involving the posterior margin of the vertebral body along with the overlying cartilage and annulus fibrosus. The fragment has an irregular shape. It is seen in older children and adolescents. Type 3. The fracture fragment is larger than the vertebral rim and leaves a round defect in the adjacent bone. It is seen more frequently in adults. Okay, thank you.